I think I only saw CME.
I did not see a lot of people actually.
Yeah.
And we have one other guy sometimes. So I saw him in one of the lectures on assumption, and I was so upset, like, well, I'm like so upset. And then next day I saw him, he goes, I was at the reception, I didn't see you.
Yeah, there
I
were just
didn't
too
see
many
you
people
either.
there, so many.
Yeah.
I think I saw you back in the day, but by the time I got over to where you were, when I saw you guys, it was clear.
AE meetings are not good
Catch up time.
I mean,
Yeah.
you see so many people, unless you say like, okay, we need to meet somewhere, go, coffee shop and sit there. Alright, or lunch.
普通にドリルでいいですか？だってさ、サイン出せるときさ、ラウンドでもいい。
You're good. I'll see you guys later.
あ、やってます。
Sure.
普通にじゃあいい。
Which one do you do? Correct? Okay. Welcome everybody. It's great to see you all, and we'll spend the whole day together. Very important this afternoon, going over positioning and everything with the surgery. Before we get to the replantation, I just want to show a quick video demonstrating what we did with the bone crushing. Are you good translating, or doesn't matter? Or?
骨を砕くのとかこうちょっとお見せするけど、特にその通訳しなくて見てればいいよね。もし何か質問があれば手を。Well, they don't have to. I don't have to translate.
Oh, you don't have to. They speak English as good as Koski, or as good as you. See, Hiroshi doesn't know when I'm making fun of him. That's how I know that his English is. So you don't have to pause.
Questions they can ask.
Okay, but okay, I don't have to translate. Okay, thanks. So this was a case that we did 6 months ago, but I want to demonstrate. Dr. Trope put it in my head about we cut the bone window out, and then after we work, we put the bone window back, and we keep it bathed in Hank's Balance solution. But he got it in my head that we're cutting off the blood supply, and we're putting a piece of bone back, and now we're putting graft here, and we're putting a membrane here, and we're putting foundation around the edges. So where is that blood supply coming from? So we've now been doing, once we take the bone out, we mush it up and we create sticky bone, it's called. If we draw blood, then we actually, once we press the PRF and get liquid on the bottom, we use that with the bone after we mush the bone up, and then we put this back into the site. So today I did not draw blood from the patient, but we did take her bone and mush it up and mixed it with sterile saline to put it back, okay? So we'll go through this. We'll go real quick. I just wanted to demonstrate some of the parts. Okay. So, and please stop with any questions. In this case, we're just doing a small square, like the mesial. And remember what I said, with the piezo, you can feel when it goes through the cortical bone, almost like going to pulp chamber, okay? And don't make a perfect square, go a little bit beyond so that you have something to wedge in. So you know that you're ready for the window to come out. Okay, so now this is what we did. You take that bone, and mush it. Now tell the patient not to be nervous. They hear boom, boom, like, you know, what they're doing. Now look, it is so as you rotate, you turn it so that you're hitting all the parts of the bone, okay? And now we use a little bit of sterile saline and mix it, and now there's your sticky bone. So that's exactly what we did today. Now, this is not today, but what we do is after spinning the blood at 1200 RPM for, 2700 RPM for 12 minutes, then we cut this, half there, mush it down. This is gonna act as the graft material, right? And then we flatten the rest. That's gonna be the graft. Today we use foundation as the graft. And then that's gonna be the membrane. Today we wouldn't even need a membrane to cover. And now, here is the liquid that's left, and we use that to keep the graft moist, hydrated, keep the membrane hydrated, and now we're gonna make a sandwich. So for today, I did not use the bone. I'm sorry, I did not, I used foundation in there. So first we get bleeding, and then I put a little bit of foundation. In this case, that's the graft, right? The PRF graft. And now you make a sandwich, and there's the sticky bone, which is what we did today. So when I put the foundation in, I kinda just spread it inside so that when I put this sticky bone in, it doesn't just go all out of the sight from today. The other piece, bless, and then cover, just like that. Bless you. That's how we make the PRF from the snooze in there. And then the good thing with these membranes is that it's very sticky, like a Band-Aid. It goes right down. It does, some of the collagen membranes will, like slide or move. This is very sticky and very easy to work. Any questions about this? Yes.
So, if you think about it, will we expect the relation tissue to form again in this area, or will we just have jump straight to bone formation in the healing process?
Why would we want granulation tissue?
Because it's part of healing, right?
Yeah, I mean, first of all, we obviously don't have the ability to go back into sites to see what's there. The only time that, regardless of what you use, whether you use just a blood clot, grafting material, PRF, bone, anything, the only mistake that people made, and I've showed slides of this, is when you just stuff it so much that there's no room for any kind of blood supply. So I'm not thinking, oh, I want that to regranulate per se. I'm thinking I want that blood supply getting in there. I want that clot to get in there. And basically, all these, because a lot of this stuff would heal with nothing, right? Especially these kind of lesions, which are, you know, classification B or C, which is just at the apex. It's going to heal regardless of what you do. So you're really just stabilizing the blood clot, where you're stabilizing it with sticky bone, bioos, PRF, and then you're covering it so that it doesn't fall out to allow it to heal. Now the beauty of autologous bone and the grafting material is that you don't have to put the patient on antibiotics, right? Because they cannot reject it. It's their own bone, and that's what I like, because I think antibiotics are way too overprescribed. And if you draw the blood, you could use 2-4 cups. You can make as much as you need. Periodontists charge like $600, and it's so funny because it's coming right from there's no cost other than that. Okay. So what time is lunch down here? Like 12:30 or 12?
I think it says
12. That would be enough time. Yeah.
It
12.
says 12 to 1:30.
Okay, good, which will be here. Okay. So for the next hour, let's say, I want to talk about replantation, and it's basically when you cannot do surgery and you've treated the cases, you've retreated the cases, and now you need to be able to think outside the box of what I'm going to do to fix this problem, okay? So by the end of today, I want everybody to be comfortable doing from here to here surgery, up and bottom, up to the first molars, okay? But we're going to talk about cases and why we choose to do replantation, where we're taking the tooth out and fixing and putting it back in. So we're going to discuss each of these. Now, the most important part is the treatment planning, meaning you have to be able to look at x-ray and CBCT and think, I can get this tooth out without breaking it, okay? So when the roots are like this, no, I'm not doing a replantation. When the roots are straight and there's bone in between, that's the very best. I don't talk about this in detail. When the roots are fused, like C-shaped canals, that's easy to extract, but when you put it back, it's more loose, okay? So we'll talk about techniques to get the tooth out without breaking it. The problem is, from here up, a lot of these cases have root canal retreatment post, core buildup, crown, so very fragile. So you go to take it out and it breaks right at this level, and then it becomes extraction. So every patient has to know we're trying to save the tooth, but the patient has to be prepared to have extraction, all right? If the patient's like, can you guarantee me that you can, no, that's not a good replantation. It's patients that have had root canal, retreatment, antibiotics, bite adjustment, new crown, all this stuff, and they're like, enough, I want to have my tooth out. Those patients are the best because they're prepared to have the tooth extracted and have an implant. And now if you can save the tooth, you're, a hero for them. Once the tooth is out, it is so easy because you really don't even need a microscope, right? I use the resection with the same burr that I use for the surgery, the Lindemann burr, cut it. And you don't have to worry, like today, I had to be careful, is my ultrasonic this way, this way, this way? With that, you're staring right at it with high speed, okay? And then we're using the bioceramic putty. And even though I tell the residents, let's try to keep it within about 15 minutes, the Hanks Balance solution will maintain the periodontal ligament, the PDL, for 30 minutes. So once the tooth is out, there's no rush at all, okay? Very relaxed. If you are not taking pictures, filming it, you could, from the time it goes out to go back in 5 minutes. It's that easy, okay? but we take time and we take photographs and videotape, so it usually takes us somewhere between 10 to 12 minutes. Now, one of the best parts is people think, oh, when you put the tooth back, oh, it's gonna be very loose. No, I may be splinted 15%, 15% of the time. You know why? Because the goal when you take the tooth out is not like as fast as possible. The goal is to gently luxate it and rotate, so in essence, you're causing inflammation in the socket and expanding the bone. So it's a gentle rocking motion, trying to go this way or this way to expand the bone so that you can get the tooth out. When I replant the tooth, then I take the bone and I squeeze, right? And I have the patient bite on cotton roll 2x2, and then I check after about 10 minutes if the tooth is mobile. If the tooth is +1 or less, do not splint it, because you actually do not want to cause ankylosis. You want to allow for physiologic mobility. If the tooth, is very loose, then of course we have to splint, and we'll talk about splinting. The other thing is, since I've cut the end of the root, a lot of times the tooth is a little bit lower, so it's not in hyperocclusion. And it's very important, I give patients the gauze to bite on, and I say, bite on it the rest of the day, and I give them a pack of clean gauze, because if they go home and they start eating, then the blood clot down here could cause the tooth to come back up. So have the patient biting when they leave, and give them and say, bite the rest of the day except eating or drinking, okay, to keep that tooth down and prevent it from coming up. As it heals, we notice the PDL healing, and then the bone will heal. Now, this is very, very important. When you take the tooth out, you are cutting the periodontal ligament, okay? So when you're going like this and you're pulling the tooth out, you're separating the periodontal ligament. Some of it is on root, and we keep the root in Hank's balance solution, but there's also periodontal ligament here. And there's actually papers from Japan that talk about do not scrape that, right? So when you take the tooth out, granulation tissue comes with it, and you can remove some tissue if you need to, but do not scrape the walls of that socket, or else you'll be taking away. You came here to get me coffee, Frank. Thank you so much. I appreciate that. Sure, I love that. So, let's talk about reasons why we would do
Decaf, right?
No, I don't even. That's poison. Just regular, but a little cream and a sweet and low, please. Thank you so much. So, the reason why most common,
So when you extract, sometimes also more in the coronal part, you get a little bit of bone sticking to the.
That's a good question. Sometimes between the roots.
Yeah.
Very, very good question. Thanks. What Phil's saying is, when you take out the tooth, sometimes when there's bone there, the bone comes with that. I'll actually try to leave that there if possible. I don't want to take that out. I'm going to want to leave that, septal bone. Problem is, while you're extracting the tooth, thank you so much.
It's stirred, not shaken.
Okay. That's for Hiroshi usually drinks scotch with milk, right?
Yeah.
Is that what he's? Ask him. He drinks whiskey and milk. This guy. I don't know something about it. Yes. So what happens sometimes? Thanks, Frankie. When you're luxating, without knowing, you might get little micro cracks, micro fractures, right, of the bone. Sometimes the alveolus will chip away. I have had cases where patient comes back either on the lingual buccal, and like a month later, they're like, I feel like a fishbone, or I feel something sharp, and you can have a little spicule come similar to an extraction, where there's a little bit of fried bone. So I think that, but if the bone isn't there, it's a good point to keep it there. Now, why second molars are the most common to do replantation is that as we go distally, the roots are more curved lingually. So the bone is much thicker here, not to mention being able to, retract the patient's lip in order to reach it. So here are the statistics, and that's why all of you will be comfortable doing first molars later. You have about 4 to 5 millimeters of bone. When we first started using the piezotome, our cutoff was about 3 millimeters, 2 to 3 millimeters of bone to cut a nice window. Today I had 2.5 millimeters of bone, but now it's irrelevant because I'm mushing it anyhow to put it back. But it's easy to reach here, and this is acceptable whether you're cutting an osteotomy or cutting a window. And look at this, like in order to reach that distal root, besides pulling the patient's cheek, you'd have to cut 8.5 millimeters of bone just to get to the root, but then you have to cut through the root. And if you notice, and Chrissy asked me today, how come I didn't complete the resection with the piezo? You can, that's no problem. The piezo does an absolutely flat bevel, and we want 0 angle, but I also like to have a slight positive so that I can see direct. And that mesial root, I don't know if you noticed that it was like curving mesially, so I had a good view with my burr. But when you're buried in there, the piezo is great because you don't have the head of the handpiece like blocking your vision, right? The piezo comes like this, like an angle, and you have perfect view of it. So piezo is very good for resecting off the root when it's very deep inside there. And of course, we're using our CBCT now, so we see how far lingually these teeth are, and there's no way we're doing lingual surgery, right? So that's why the replantation is so common. Now, this case is from my office, Dr. Lee, and I hate doing retreatments. That's my least favorite thing. Surgery and replantation is my most favorite thing. And with retreatments, it's very hard to make them perfect, right? Like, a lot of times I can't get down the canal, I can't find the canal, or I go to remove previous gutta percha and I push it through the root. Like, retreatments are very unpredictable, and replantation, it's difficult, but you have the straight root. But we see this a lot from retreatments, and we do the best job that we can. This tooth was removed. There is the excess gutta percha with the granulation tissue around it. There's post-op, and just to let you know, this is not something that only lasts, a few months. We have cases, years and years of success. If there's a crown on the tooth, always keep temporary cement handy. I used to think, wow, if the crown comes off but no damage, then I'll replant the tooth, leave the crown off so there's no contact, it will heal nicely. The problem is the tooth will start to shift, and in 1 week the patient is still kind of sore. You don't want to start manipulating, putting a crown on, and then 2 weeks or 3 weeks the tooth's going to move. So if there is a crown, I always keep temporary cement, and if it comes off, I do the work, and then I put some temporary cement and put the crown back on, and then replant it. Okay. This is a case from my other partner, Dr. Yang, and it goes to show you that from doing retreatments, the thing that I hate most is fiber posts, right? It's very difficult to remove fiber posts. If you use ultrasonics, it's gonna be all black and mushy. You have to drill these. Now, the person who referred the case to us goes to Las Vegas, Nevada to take these very expensive courses on how to market, on how to do very expensive cases, okay? He's a general dentist. So at this course, they taught him to place a fiber post in every single root of the molar and then charge 3 times the cost of a fiber post. So they're fiber posts in both mesials and the distal, okay? So doing a retreatment here would be very, very difficult. Now, look at this. This looks like a pretty good root canal, okay? All the time we're seeing these C shapes. Now, with XP shapers, finishers, gentle wave, lasers, whatever you want to use, sake, anything that you use, it we're doing a better job getting into the areas, but I can't tell you how many times we do a replantation and we see a root canal looks pretty good, and then we see this huge C shape. And look at the staining there, right? It's very difficult to get to this. So we take just a 330 or 245 burr and basically connect it, and we use the bioceramic putty over there. People say, why don't you use an ultrasonic? Why do you use a burr? Very simple, ultrasonic just takes more time, okay? The only time I would use ultrasonic is when I look here, if this is very narrow and I'm worried right here, use a high speed, then I might just use an ultrasonic because it's thinner. But ultrasonic would take 5 times as much time as a high speed burr. And then here we have a post-op, 8-month, 2-year follow-up. Also, you have the cases where the mental nerve is right on top of the bicuspid area, or sometimes here, or you have a root that's down by the mandibular nerve, and you're worried by doing surgery that you can cause some post-op paresthesia. So another good reason to do a replantation. We have, used to have only Panorex film, and now we have CBCT, so you can trace that to see where that mental foramen is. There's no way I'm gonna do surgery right there on that tooth. And of course, we recommend CBCT, and the CBCT will show you right there, okay? So what this is showing me is that here is the buccal surface. That's where the mental foramen comes out, mental nerve comes out. Here's the granulation tissue, okay? So if you were to raise a flap, your retractor has to go here, right? You can't retract here because you have the mental nerve coming out. So you'd have to retract up here, so you'd cut off all this and take away this bone, and when you're here working, it's going to be very difficult because there's granulation tissue and the nerve there. So a case like this, I would highly recommend doing a replantation. And I'll show a video. Serene is one of our residents. When she did a retreatment on the case, the nice job, like size 60. Patient got a post and a crown, was having symptoms. Here is the 3D rendering from the Merida, and you can see here that the canal is going down, mandibular nerve is going down, looping up here, and then there's the mental, all right? So here is some images, but I'm going to show you videotape, and I wouldn't even say that she missed a canal. It's definitely one of these like ribbon-shaped canals or figure-8-shaped canal filled with putty, but I show this case because she did a very nice job with the video. With the bicuspid, you could also do rotation in addition to luxating back and forth. The Hanks balance solution is red. You can see we're keeping it moist. Now, we've changed something. We now turn the water off. We don't cut wet because there's studies that show that the sterile water could dry the roof. So we turn the water off and we only use Hanks balance solution. And now she's just gonna take a high speed, prep it. You could use either a 245 or a 330, and we try to get down a depth of 3 millimeters. Go a little further if you want. Now, she's using a hybrid technique. First dry with Strop Co. She's going to put a little BC sealer in first. If you do this, always leave room to put putty on top. So this is a hybrid technique. You could either use a root repair material, a sealer, but if you notice, she left room for the hard, fast set putty, because you want to make sure that that sealer doesn't start leaking out of the prep, okay? So now she's going to put the tooth back in and compress the bone. We'll talk about the forceps a little bit later on. And then the tooth goes back in. Make sure you know what buccal and lingual is, so you put the tooth in the right direction, of course. Should pop back in. And now look, this is going to be very important. So she compresses the bone. Patient bites down for about 10 minutes. Now look at this. Right? That's about 10 minutes later. So no reason to do any kind of splinting. There's less than +1 mobility within 10 minutes. All right? Now, this is a case that Yashin and I published when she was full-time faculty here, that she did. First, Yashin did a retreatment of this lower bicuspid. Notice where the lesion is. Now, think about this in terms of if you wanted to do surgery, okay? So this is easy to fix, okay? You can fix this. There is this lateral lesion here. We suspect maybe a fracture. We hope maybe a large lateral canal. But let's say I wanted to do a surgery here, okay? I'd have to make my osteotomy all the way here, and I'd have to take away all this bone, and there's no way, even if I got here to clean this, how am I going to be able to see, because it's so far towards the lingual, if there was a big lateral canal, and even if it was, I can't get ultrasonic in there. So I would destroy all this bone, maybe not even be able to reach it, and definitely not see the source, okay? So much easier to pull the tooth out, and then you can look directly. So this had a temporary crown. Once again, always keep temporary cement because the crown came right off. And now look here. You can see some gutta percha. This is a very deep cemento enamel groove, okay? So the root goes like this. This is not a fracture. This is not a large lateral canal, but it's this groove. And you could see right here, gutta percha and the black staining, all right? So we stain with methylene blue to confirm it wasn't a fracture. There's the apex, because remember there were 2 canals. So we prep them, and we prep this groove also with a high speed, okay? So we prep the 2 roots, prep the groove, bioceramic putty, re-cement the temporary crown. There's the post-op, 1 month, 6 months, 15 months, 1 month, 6 month, 15 month. So we're comparing healing here and here. And then of course you have to look at CBCT, And the study that Shafiq Safi did while he was resident here is that with CBCT, you need about 18 months to really show healing on these surgical cases. You could take CBCTs earlier. Sometimes we see healing 6 months, 9 months, but really you need about 1.5 years to show healing. And you could see, compare here to here. It's got a little bit ways to go, but it's healing very nicely. So able to clean that and seal it by doing the extraction replant. Another reason to do replantation is if you have patients that have physical or mental disability, patient who have like tremor disorder, not able to stay still. This I could do a third molar apical if I want to. So this is a very, very good story where my partner retreated this tooth, and this is a first molar, and patient had persistent symptoms. Now, this is a little bit complicated in that she had an endoperio lesion, okay? So endoperio might be a reason that you do not do replantation. I know I could get this to heal, but when there's perio involvement, I'm worried about the furcation area, okay? So that may or may not be a good reason. Now, this first molar is a very easy surgery to do, but the patient was too anxious and refused to sign consent to have surgery. They just didn't like the word surgery, the thought of scalpel or anything. And then the patient said the magic word, says, I'd rather you just pull the tooth, okay? That's how scared they were of surgery. I know in Japan the patients are very calm all the time, right? No bad patients in Japan. They just sit like this, very nice. So once she said, I'd rather just have the tooth out, so then Ken said, fine. So we removed it, put it back. This is before putting the crown back on. Remember I said we used to leave the crown off. Here is the post-op. Here's 3 month, 6 month. Look at how nice, not only apex, but in the furcation. At 1 year, the patient said, I'm having pain on the other side, okay? So this patient was too scared for surgery, but she was so happy. At 1 year, she says, take a picture of the other side, and the other side has 2 separated files, okay? So unless you want to move to Japan and see Dr. Teriuchi with his file, removal kit, I tell Dr. Teriuchi, I get out as many files as you, but I get them out, this way, not, that way. And the patient said, I'm having the same situation here. Don't talk to me about surgery. And the patient treatment plan, a second replantation, right? Because it was so easy for her. So then here is the post-op of the left side, 3 month, 6 month, and a 1 year here equals 2 years here, okay? So we find that the patients are very acceptable to this, and considering that the work is done outside their mouth, once the tooth comes out, it's a very relaxed procedure for them, not something so nervous about like doing surgery. Now, how about a case like this, where you have a post? These are difficult for any surgery, by the way, because you can't cut off 3 millimeters and get a good seal here. That's one thing. But let's say I wanted to do surgery on this tooth, and you have a healthy root. So you're coming in like this, you're cutting through healthy bone, cutting through healthy root just to get to here. So now, by the time I'm done, look at the ratio of the crown of the tooth to the root, okay? So something like this, you could take the tooth out and just address here. Now, a lot of times there are cases where I've chosen just to do the root end section, on the root that has the infection. When I'm doing typical surgery, I'm only working on the root where the problem is. When I'm doing a replantation, most of the time, if it's even a question, I'm like, well, tooth's out, very easy to do all the roots. On a case like this, if this is healthy and I need this for stability, I'll leave that alone and I'll just address this, and I'll try to just cut off a little bit of the root and get the BC putty to seal around there, okay? So that's a good reason for that. And this is one of Dr. Setzer's cases where he has both a lesion around the roots, but there's also post-perforation here. So here is the root with the granulation tissue. Now, very important question is, I've told you, don't scrape the roots, right? There could be PDL that's live right here because we're keeping it moist with the Hank's balance. Now, when the tissue comes with the root, that's fine. We're going to cut this root off. It's going to be fine. Sometimes the tissue is stuck over here, and you'd love to take a curette or something and really clean it. What I do is I'll take tissue forceps and I'll try to remove it, but I really don't want to like scrape this. I'd rather leave a little bit of tissue here. Remember, granulation tissue, once again, is inflammatory and it could help with healing. It's not like there's bacteria there, but I'll pluck off what I can, but I don't want to scrape the root. I'd rather leave a little bit. There's his root end filling. So he sealed both the ends of the roots and the post-perforation site. And here's the final. There's 12-month follow-up. And look at the 24-month, 2-year follow-up. And remember, because Frank did extraction replantation, he never had to cut through all that cortical bone. So you're really preserving, you're saving all this bone by doing a replantation. And there's the mesial root as well. So it's more conservative, less damage to bone. And once you get the tooth out, it's simple, and patients are sitting there and watching it on the screen. So I mentioned at the very beginning, the best case selection is the one in the middle, because not only are the roots straight, but you have a little bit of bone in between the roots. So when you go to replant this, it's going to be very steady without much mobility at all. This is a good candidate for extraction, but bad in that with the fused root, then you're going to have to do splinting most likely because of mobility, and then this is just bad in terms of being able to take it out. Here's an example where the referring dentist calls all week to ask advice about a patient in pain, and then waits till Friday when he's golfing to say, now it's an emergency, okay? So he sends this on an emergency on a Friday, and this is a this is a disaster, okay? Second molar, this is a cast post, right, and core, and you have the excess gutta percha. So first of all, if you want to drill this out, you'll probably fracture the tooth, and it'll probably take you 2 hours to cut. So you have to cut all the way down to the level of the cast post and then try to get this out. Then if you do that, when you go to take the gutta percha out, what's going to happen here is it's probably going to snap, and this is going to end up even getting further away. So this is a nightmare for an emergency or any time to do a retreat. So we did an intentional replantation on emergency on a Friday afternoon. Now, why this is such a good case is that we took this x-ray halfway through the treatment. I'll explain why. Usually when I take a tooth out, I know that it's in one piece, so I don't take an x-ray. But when we took the tooth out, we were looking for this and hoping that it didn't separate. So we're staying with methylene blue. We don't see the gutta percha, so we take the x-ray. Thankfully, the gutta percha came out with the tooth, but this shows exactly what I'm talking about, which is that bone in between the root makes this a perfect case, because when this tooth goes back in, it pops right back in. There is no mobility at all. So there is the post-op, 6-week, 5-month, 1 year, 2 year follow-up.
Was there a problem with the 6 as well?
Excuse me?
Was there a problem with the 6 if you go back? And then you get rid of the 6? 2 for 1 deal.
I don't see it here. You talking about here maybe?
Yeah. Does that not look like a radiolucency of the 6?
I don't know. I probably was ignoring that, so we'd have to take a
Wait for the next emergency.
yeah, we'd have to take a CBCT, and that would be a more doable either retreat or apex on there. One of Me Too's cases where she did a nice job on upper second molar, okay, and here is her post-op. At 6 months, the patient returns and is having symptoms. Now, Me Too did 4 canals. So you have MB1 and MB2, distal and palatal, but when you look at the coronal view of the mesial root, you see MB1 and MB2 and they merge, but there is this split going apically. So this is very, very difficult, if not impossible to treat. Now, keep an eye here. There is a break in the bone from the infection, and look at how thick the sinus membrane is. This is all mucus and patient extremely congested, having difficulty breathing on that side. So Me Too takes the tooth out, and now once you cut back, remember there was MB1 and MB2 merged, but once you cut this back, now you can see that's the apical split, right? So the 2 canals merge, MB1 and MB2, and then there was a split. So once we cut the root, now we can address that split, and she connects the dots, and here is her root end filling. There's a 1 year follow-up, which looks nice. Patient's very happy. And look at the difference not only in the bony pattern, so here is the pre-op, here's 1 year later, but look at how much the sinus has cleared up. This is all mucus, and now this is, excuse me, what a healthy sinus looks like, maybe just a little thing. So Me Too solved the tooth problem, and now patient could breathe even better on that side. So this is those cases, and we've had lectures for the residents with these cases up near the sinuses, how you cannot always say, but oftentimes one is a result of the other. You could have a terrible infection in a tooth that's causing sinusitis, or of course you could have chronic sinus issues where patients come to you and they have pain in like 2 or 3 teeth. All right, so position of the forceps, as best you can, try to keep them above the CJ area, okay? I know that it's easy to slip, but you're basically doing, this is showing you're doing a gentle buccal lingual luxation. So your goal is to expand those plates of bone to make the tooth able to come out. Not a fast motion, not a jerking motion, and also, in addition to the buccal lingual luxation, we recommend some slight rotation as well. The rubber band here, one of my teachers, Dr. Nimzik, used to do that just to stabilize the handle there. So I know that the forceps are going to slip. People ask me, do you use elevators? It's very difficult in my hands to use the elevator because it's slips, and then I'm worried about damaging PDL. So the goal is to, as best as possible, limit the damage to PDL, but keep in mind, even when you're luxating a tooth, you're going to have some resorption here because you're going like this to take the tooth out, okay? Now, the motion is you go buccally and you pause, you go lingually and you pause, then you do some rotation, and then you can take off the forceps and allow for inflammation. And then you go again, and you go a little bit more, and you go a little bit more, rotation and pause. So the goal is to slowly get it to expand so that you come back and it's starting to get loose, okay? So once again, it's not this kind of a motion. It's a motion, pause, let some inflammation, come back, pause a little bit, and give it time for the bone to expand. These are the forceps that we use, and I'll show another picture of them. And like I said, either 245 or 330 burr. The position of the forceps allows you to have a very good grip on the crown of the tooth, the way that the forceps are curved like this. Now, when I said try to keep the forceps, at the CJ level and try to prevent from them slipping, or if you're going to use an elevator, if you can't get the tooth out, be very careful. Remember, below the CEJ, you have about 2 millimeters of biologic width, okay? So you have about 2 millimeters in case the forceps are slipping, or the periosteal elevator you want to use or the elevators to try to get it out, of both a millimeter of junctional epithelium, millimeter of connective tissue. So the biologic width is about 2 millimeters. So the periodontal ligament really doesn't start until the bone level here, right? So you do have a couple of millimeters in case you're having difficulty, okay? So don't stress it too much. And these are the forceps, and I believe we're gonna give you a catalog later, or a list of where you can get all the different supplies you might want, and I'm happy to answer any questions. But this is from Schumacher, which is a German oral surgery company, very high quality, instruments. And the three things that I like are, there's more edges here to give you more gripping surface. The occlusal shape gives it a good grip, like I took the picture before, on the crown of the tooth. And then what's good with this is it prevents you from slipping down, okay? So do not use cow horn forceps. Do not use forceps that are gonna grab into the furcation, because then you're gonna damage that, okay? So no cow horn forceps. We have these two upstairs in the surgery suite, so this afternoon after lunch, we'll look at all of them together, and we'll go over instruments with you, either myself or Dr. Kim, and you'll be able to feel all these. Now, a little trick here, before you replant the tooth, you can have the patient come to you maybe 1 to 2 weeks ahead of time, and you can put these orthodontic spacers in between the teeth. This is, I should put her name, Vicky Chang, one of our residents, made this nice slide for me. And the spacers here is what orthodontists use prior to placing brackets to open up the embrasure spaces. And this would be nice because this will cause a little bit of inflammation and maybe give you a tiny bit of mobility prior to doing the replant. And we use the Hanks Balance solution. If you cannot get this in Japan, I know you can get Pedialyte. You guys, can you get Hanks Balance in Japan, or?
We can get that.
Yeah, the problem with the Hanks Balance is that it's not expensive, but in the United States, it's a biohazardous chemical, so they may charge $20 for the bottle, but then $40 to ship it because it's biohazard material. This you get in a supermarket, and it has the same ingredients as the Hank's Balance, and we keep them in a refrigerator to keep the shelf life alive, because a bottle like this could last for several replantations. We keep a basin here. The Hank's Balance has red coloring, it's just phenol coloring, doesn't do anything to the chemical, and this way when we're working and we're irrigating, it doesn't go all over the place. So we're using syringe with the Hank's Balance, and we're keeping the high-speed water turned off. This case I did with my resident Nora. She graduated a couple years ago. She works in Mitu Kohli's office. Patient came here with this upper second molar. You could see quite a overfill, right? Now, what's interesting is that the two buccal roots had huge overfills with sealer and gutta percha, but the easiest root they didn't treat, right? So you get a lot of strange things in the US that get referred to you that make no sense. So you have a big overfill and it's going into the sinus, right? And then you have an easy root that's wide open that they didn't treat. So of course, first Nora did a retreatment of this root. I did not want her to do retreatment because it was already in the sinus, and I was afraid if she tried to remove the gutta percha, the rest would float away, okay? So, and these are the different views. There's the sealer, actually in the sinus. So we're gonna show a videotape here. So there's Nora taking out the tooth. And I was hoping the gutta percha would come, but there's the gutta percha in the sinus. So Nora is busy dealing with the tooth, and now this is me praying and trying to get the sealer and the gutta percha out from the sinus. So what happened is that I had trouble reaching it, so I had to cut away the bone in between the two buccal roots. And then I used the gutta percha removal instrument that's very sharp and was able to grab onto that and pull that out, okay? And that's the piece that came out, and at that time, I knew that there was probably more in there, okay? But I just want to show what we used here is that I was trying to get that gutta percha out, but I couldn't get around it to get it, so I took away the bone here, and that allowed me to get my instrument beyond it. And this is a very, very sharp tip here that if you go like that, it would cut your skin, and I was able to grab it and pull out the sealer with the granulation tissue. Now, said to the patient, you might have, because I knew that there was more gutta percha up there, I said to the patient, you might, blow your nose and find some orange in there, all right? So patient called the next day, says she feels very good, but she coughed and a piece of rubber came out of her mouth, not the nose, but it went through and came out the mouth. But she said, I saved it for you if you want the little piece of gutta percha. I'm like, I can make, what do you do with sushi? You add a little eggs on top, or a little, like a little, put it on a cracker to, I don't know what you would do with this excess gutta percha. Now, because I had to break through the bone here, the tooth was loose when we went to put it back. So Nora created this splint, and I'll show pictures of it, but this is a fiberglass splint with composite covering it, right, called ribbon, or we have the ropes over here that we use glass span, I'll show pictures, and that kept it stabilized enough for 4 weeks, and then when the patient came back for follow-up, we were able to separate that. And so far we have a 6-month follow-up, and you could see nice healing. We have to get the patient in for further follow-up. But there's a 6-month follow-up, and you can see the bone is nicely healed there. And patients should get a more definitive restoration like crown on there. Now in terms of splinting, as I said, only splint it if you have more than +1 mobility. And this is very easy. If you don't have the time or don't want to use that fiberglass, and I'll show that in a minute, you could just use sutures to passively hold the tooth down. And you just pick up the tissue here, come over here, pick it up, tie it, pick it up here, go here, or go twice across and just passively hold it down. I wouldn't keep that suture there more than about a week, just to keep the tooth in place, because you want to allow for physiologic mobility. People often say, do you ever lift a flat back? Do you do these, with the scalpel first? And the answer is no. As long as I have a good part of the tooth to grab on, there's no need to open it up, right? If the gum tissue is above the CEJ, sometimes I might just lift the papilla back in order to grab the tooth, and in those cases, then you can pick that papilla up and it makes it a little bit easier to place the suture. But almost close to 100% of the time, there's no need to do any kind of soft tissue elevation. And we have this upstairs in the clinic. It's similar to the rib bond, which is flat, but this is a hollow rope of fiberglass, and it has etch and bond. And basically, if you know you're going to splint because the tooth's mobile already, then ahead of time you could plan this, and the rope is sealed with wax, but once you cut it and take the wax off, now this is hollow, so you can put the flowable composite in there, and it's flexible, and then lay it down in the groove, cover it with composite, and cure it. And this is what it looks like. So this tooth already had some mobility, and we're doing a replantation. This tooth had root canal done. They both had crowns. So before taking the tooth out, cut a little groove here, right, in the crown. It's called the dovetail for retention. And now the tooth that's being removed, you can cut it as deep as you want, and you can go to this part, beyond the mid-occlusal of it. And before I take the tooth out, I'm gonna measure that rope, okay, just to make it go quicker at the end, just to estimate it. Do your replantation. After replant it, you etch bond the groove, then you put composite through the rope, lay the rope down, cover the rope with more composite, and then cure it, and then you can polish it, and that's what the fiberglass splint would look like. Now, to be honest, fiberglass, it's pretty stiff, but it's considered a semi-rigid. It's not a thick gauge wire, so it's considered semi-rigid, even though it's stiff. If I have a case where the tooth was very loose to begin with and a big lesion, I may leave this for 3 to 6 months, right? Just to make sure that this tooth tightens. Because once you sever this, I don't want to have to re-splint that tooth. So I want to see some healing of the bone and make sure that there's some stability. And I've left it on as long as 6 months before separating it. I'm not so worried about resorption as much as I'm worried about movement. Now, you're going to say, do you need to have a CBCT? The answer is yes. And this case, Dr. Trope brought in for me to do a replantation in the clinic here on his patient. In his office, he had trouble finding the canals, so he brought the patient here to Penn. I want to show you something from the cone beam. Right there, okay. So, look at the difference between, from a PA film, you really cannot appreciate the curvature versus the CBCT, okay? So let's talk about this and figure out how I plan on taking the tooth out, all right? So this is the buccal, here is the lingual, here is the curvature. So think about it. If I take the tooth and I luxate lingually, this root will go here and it will break, right? Because the root's like this. So if I luxate lingually, this root has to travel all the way here, most likely will break. If we luxate it buccally, then we're actually using this curvature in order to help us get the tooth out. And it's so thin here that it's much easier to do this than doing that and having it go against that, right? So we're using the CBCT in order to help direct us how we're going to remove this tooth, hopefully without breaking it. Once it came out, there's the lesion, came out with the tooth, so you don't have to worry about going into the socket at all. Cut off the end of the root. Funny thing, Dr. Trope said, well, let me see if I could instrument it from the other end, but it was very calcified. And at this point, this is prior to using BC Putty, we were using the gray MTA at that point, okay? And I apologize, it's his private patient, so I don't have any follow-up to show you. Just the pre-op, CBCT, and post-op. All right, so important to take CBCTs for every surgical case. Last case I'm going to show you, we're running a little bit ahead of schedule. We'll try to get lunch a little early, we'll take a break and then come back here for lunch. This is a second-year resident, ended up going work for Dr. Coley, right? And this shows you don't need to be practicing many years, because we all in dental school learn how to extract teeth, and it's a perfect situation. Second molar, we look at the CBCT. It's 10.5 millimeters from the buccal to the lingual aspect. Patient is symptomatic. There's a lesion here, somewhat fused root, which makes it a little bit easier to take the tooth out. And we're going to share this video. Melanie did a great job making the video. So we check ahead of time with a perio probe. As I said, sometimes if it's a if it's an endoperio, then you're contraindicated maybe for doing the replant. Here's the motion. It's already obviously loose, so we tell the assistant get the Hank's balance ready. Have the patient biting down on gauze while we're doing the work. Those are the forceps that we use, trying to keep it right around the crown margin area. Keeping it moist the whole time with Hank's balance solution. The water is turned off from the handpiece. And now, when we stain this, look, once again, it's going to be a huge C-shaped canal. So you're going to see those two blue dots, spaces that were not reached when we did the initial root canal, and just going to connect all the dots. And go all the way around to incorporate the canals. See, connect everything. Keeping it moist while we're doing it. Now you dry the prep. There's the BC Putty. Make sure that the resident has their elbow against the, top of the table so they're not shaking too much because you're holding the tooth in your hand. Gently pack it. And then when you're done, just use a bowl burnisher. I used this today when I did the surgery as well. And then we'll just wipe it, make sure it's clean, and then the tooth will go back into the socket. Pop it back in. You'll see it will make like a popping, whereas you're going to compress tissue, and there's 10 minutes later, look. Right? So no need to splint it. In fact, the splint can promote ankylosis. Once again, about 10 minutes later. And then we'll check the bite, and if there's any hyperocclusion, I might take, so we'll have them biting on some articulating paper, and if necessary, then make a little bit of a bite adjustment for the occlusion. So your patients are gonna wanna know what the success rate is. There's a lot of literature out there going back to the 60s. Some of these old studies, they did replantation on teeth that did not have root canals done on them. So be careful when you're reading the literature. Famous I.B. Bender, it was Grossman, Bender, and Seltzer. He had a 22-year follow-up. It was on his second molar that had a replantation done. But in 2015, Torbinaj did a review and of articles from 66 to 214 and had a success rate for replantation of 88%. Then in 2017, Maincard did similar with a little bit longer follow-up from 66 to 17 of different articles, and success even a little bit high, so 89.1%. So this, when a patient asks you, now it's a very tricky question that I'm always asked, so I'm gonna say it right now. You're gonna ask me, how many times do I start doing a replantation and it fails, meaning it's cracked? That's a very difficult question to ask because all these articles are assuming a successful extraction of the tooth, okay? So when the tooth is successfully taken out and replanted, now we're talking this kind of success rate. And the number one reason for failure, the two biggest reasons after replanting, would be either resorption, and it's from rocking tooth having a very difficult, extraction, and the resorption, if that's gonna be the source of failure, will usually happen within the first year, or the patient ends up fracturing the tooth somewhere down. So those are the two reasons why these cases will fail. But I can't give you an honest answer because in private practice, I will do less replantations because more of the patients are getting implants and I'm not being as aggressive. At Penn, I'm being more aggressive, attempting more root canals. So when I attempt a replantation, when I attempt a replantation, it could be cracked already, right? I may not cause the crack, or I may cause the crack, or it might be ankylosed to begin with and you can't get the tooth out. So you really can't answer what's the success rate of taking the tooth out. If I want to just take out perfect teeth, then I can say, okay, I have 100%, success of taking the tooth out. Then the root is going to be like that. Okay, so that's a difficult question to answer. These two statements are important. Is that compared with a single tooth implant, a replantation is more cost effective, means cheaper, even if you need to do a new post-coron crown afterwards. And intentional replantation is something that really should be discussed and should be in the back of your mind as possibility to do with your patients. Okay? Let's answer any questions, comments, and then, Phil.
So when you extract the tooth with the forceps, I see many other dentists using then wet gauze to hold the tooth. What's your rationale not to use a gauze?
Quite simply because, I mean, instead of the forceps.
Yeah.
So I don't want, even if the gauze is soaked in Hank's Balance or in saline, I don't wanna have too much contact with the root surface if I don't have to. So the beauty of the forceps is that I'm trying to keep it, and there are times where forceps might slip down a little bit while I'm taking out the tooth. Once I take it out, then I could reposition those forceps. So number one, you have a tight grip, but I just don't I don't wanna scrape that root if there's tissue there. I just don't want as much handling, but, you know, for years, that's all they're doing. I would recommend, because Raylan Wong, one of our residents, did his master's on the different, transport medium. And by far, the Hank's Balance is the best for maintaining the PDL. One of the things that he kept the tooth bathed in was saline. And the saline did allow for some resorption to occur. So it wanna be moist in Hank's Balance. So if you wanna hold it, grip it with a gauze, at least I'd soak those gauze in Hank's Balance instead of having saline. Yeah, good question. Anything else, guys? Everybody ready to do replantation? Yep.
And could we place some, I don't know, rubber protection on the forceps to make it less?
There are forceps called physics forceps that have like some rubber bumpers on there. The ones that I've had that had the rubber, I don't think gives you quite as strong of a grip, but that's fine. Another question that's often asked is, do I treat the socket? In Europe for a while, they were using Emdogain, you know, some kind of a gel in the socket. You could rinse the socket with the chlorhexidine if you want, but I typically don't treat the socket at all. If there's a big chunk of granulation tissue in there, I'll pluck that out, but I never scrape the walls. Yes, sir. Oh, no problem. I'm psyched for the question, because lunch isn't here yet.
What is do you have any experience on mixing not sealer with putty, but sealer with MTA? Is that a...
Well, the putty is MTA. It's just the new generation, and you don't have to mix it. So they're all bioceramics. I'm just looking for time reasons. Like, the sealer is okay if you have like a deeper prep, or you want to put in a layer of it, but always place the putty on top. I obviously for years did MTA. Two negatives. Number one, you have to mix it at the right moment. So you need a separate assistant that's good at mixing that. If it's too soft, it's gonna just fly out. Too hard, not gonna get it. Very funny story is that Dr. Lee, when he was a resident, used MTA on a replantation, and then he took the tooth after the MTA, put it in the Hank's Balance, and he put it back in the mouth. We take the final X-ray, there was no MTA, right? It washed out. So we had to take the tooth out again and put more MTA and put it, so he asked me for credit for 2 replantations. I said, no, just 1. But the other beauty with the putty, the best thing about the putty is that it's pre-mixed, so you just squirt a little bit, and it's hydrophilic. So if you notice, even at the end of my surgery today, I just needed the area dry to place it. Right after I placed it, totally fine for blood or saline on there. Hiroshi, so we have 10 minutes. We could take a break. I'll make sure we're having lunch here. The question is, I don't know, who gave the lecture yesterday? Was it Dr. Kim?
Dr. Kim.
Okay. Dr. Kim sometimes doesn't go over everything. Are there any topics that you want me to go over quickly before the lunch comes? Or you're welcome to take a little break or go to the bathroom or something, so.
なんかちょっと短い聞きたいことあるか、レクチャー的な感じで、それからまあ休んでもいいけどって言ってるけど。
Maybe yesterday we realized the ultrasonic tips, selection for different tooth and cases and positions.
Okay.
Because Dr. Kim didn't go over that when we were in the hospital. We wanted to use the right one, and some of
Oh, what did you do yesterday, the block?
Yeah. just
Okay, not the
blocks.
mannequins.
No, today's mannequins,
Yeah,
but I don't know
okay.
if you have like a quick slide that you can say, like, these are good for these teeth, this is good for this.
I don't have them
Sizes.
I don't have them labeled because I honestly, I don't even look at the number. I'll just show
Like the
you.
positioning, the double bend, the side, angle.
Yeah, it's really when you're doing the, where is my yeah, I just wanna see if I have like, pretty much start to finish one that I recently did. Let's see, surgery, here we go. Yeah, I mean, I'll show you, and I also don't care what brands you use, I'll talk more so about like the different coatings, and then we'll talk about positioning is really the most important thing. That was the part today that I was most nervous about with my surgery because I had no gutta percha to go up against. And on lower molars, it's very tricky sometimes to get the proper positioning. So do that. Okay. Let's get to the ultrasonics. Here we go. Good. Alright. This will be a little bit of a roundabout way here. There, but I'll do it. Okay. So, very important part was today, and the residents make the mistake all the time. My residents like to work at high magnification. You don't want high magnification all the time, okay? So when you're about to do your ultrasonic, why you have to go to the lowest magnification is I need to see the whole tooth. And for lower molars especially, you need to look at where that root is emerging, because the crown could be any direction, okay? So for lower molar, you cut off a curved root, you have to compensate for that. So for here, if you're looking just at high magnification, then it's gonna be very easy to go in the wrong direction, regardless of what tooth is, even anterior teeth. And the negative for this is a couple things. Number one, you're cutting dentin unnecessarily. Sometimes you can perforate it, like especially on a lower molar tooth, or I'm not getting 3 millimeters of my putty to seal the end of the root. I have maybe 1 millimeter of the putty sealing the root, the rest is floating here. So you go lowest magnification, and if you notice today, I started with the ultrasonic at the crown, and then I work my way up, and then start the prep. Now when there's gutta percha there, you want to do two things. You want to see the gutta percha coming out, right? And it should be very quiet, meaning I got the right angle and the gutta percha is like flying out. And if I'm off angle, it's gonna make a noise. This is like a ultrasonic noise because you're cutting dentin, you're not going right in the gutta percha. So those are the two things. Now we have these tips to get back to your, I think I had a slide just of the tips. I probably blotted it out. Here we go. I'll show you these. Alright, I'll show you these couple slides. Okay. So, you cut off the end of a lower molar root like I did today. You don't compensate for the curvature, and it's very easy for your ultrasonic to go off in this direction, or even more common, I'm off in this direction because it's just comfortable for me with my ultrasonic to be going here. This is like an exaggeration to get it in the proper angulation. So the prep should be done at a low enough magnification that you could not only see the crown of the tooth, but I could see where the root is emerging from the crown of the tooth. So there is the emergence, and now I know which angle to place it, okay? So you're compensating for the fact that you've cut off the curved end of the root. Now, after you do your prep, so this is what I trained with, which was a little micro handpiece with a round burr. And you just couldn't fit the handpiece into the osteotomy, so you would end up getting a little bit of filling here and cutting this. With the ultrasonics, at least it's aligned properly. Now, as I said, you know you're in the right direction because as you prep it, the gutta percha comes out and it's very quiet, okay? Now, very important. After you're doing your ultrasonic, and an ultrasonic is an up and down motion and a moving motion. Don't ever stay in one place, you'll just break the tip. Now, after you do your ultrasonic prep, when there's gutta percha there, what do is you use your mirror and you look. 99.9% of the time, if there's gutta percha, it's always on the buccal wall, right? Because you're naturally coming like this, all right? So after I do my prep and I inspect it and I see this on the buccal wall, I have two choices. I could take my condenser and I could push it down or bring the ultrasonic back in but exaggerate your elbow and then come buckling, all right? So two choices, either pack it down or go back in, and then by lifting your elbow, you're coming more buckling. Now, the different choices, and don't get worried about numbers and everything. You have the KISS tips, which are from one that's Kim Surgical tips. Those are diamond coated, very nice. These are the B&L tips from Korea, and they have projections called micro projections cut into the tip. So these might be a little bit more aggressive and maybe last a little bit longer because they don't have coating. With the diamond coated tips, what will happen is the coating will start to wear away after some time, and then they just don't become as efficient. If a tip ever breaks, doesn't matter, it doesn't bind, you just flush it out, it's not a problem. Try not to break it into the sinus if you're close there, protect it. And then the B&L has a straight tip that you could put into a bender and you can make your own bend. Now Claire was asking, which ones do I use? I don't even know. The 1, the 2, the 3, the 4, it doesn't matter. The one that just has a regular bend on it, I use 80% of the time. All anterior teeth, and the distals of lower molars, the distal of upper molars, and basically the only other tip that I use is the one that has the curve on it, and when the curve is going this way, I'm using it for left side, and then when the curve is going that way, I'm using it for right side. So don't get caught up on the numbers, but what I do is, before I start working, I already know which route I'm gonna do, and then I will pick out that ultrasonic tip that's necessary. You know where the food is?
No.
We're ready, let's go.
Where
Bring
is
it on
it?
down. I don't know. I was
no
hoping
idea.
you were the food.
No.
No?
I have a
Alright.
stupid committee meeting.
Because I'm
so I
done.
was
Don't
trying to
tell me,
grasp-
don't make the excuse that you have meetings. And then these
Who
are
knows?
just, what?
Who would know?
I think it was Brian that was it Brian who was responsible for the food? But
Oh boy,
I'm done.
we're lost. Huh?
Maybe they don't know what room the food is supposed to come into.
Huh.
Could you, I don't have any service down here, could you maybe text me? It was Brian, right? In the,
I think so, I don't know.
yeah.
Did Lisa arrange that? Did Lisa arrange
No. Just, whatever, text a couple of the residents and say, where's the food? Dr. Cashman's hungry. So these are what's cut into those B&L tips, so they use a little bit more. And once again, maybe Claire, you're looking at these shaped. I mean, these are the ones that I use, 80-90% of the time, just has a single bend on it. And there you go. That, if you want to get caught up on the numbers, they're all 1 through 6, right? Don't worry what brand it is. But it really is just saying posterior, it's not really telling
They're
you.
supposed to come here,
Yes,
this is 19B, right?
yes.
And for the size, will you ever vary the size from a 10 for the molars to the bigger one for the rear?
Yeah, so you have 369, that's what you're talking about, or fatter ones? Yeah, yeah, the one and the two are the same angle, but one is fatter than the other.
線のサクセスか。
Alright, everybody wanna take a bathroom break maybe, and I'll try to find out where the food is? Yeah.